Good afternoon, everyone. Can you hear me? Good afternoon, everyone. I would like to welcome everyone to MACB's first ever webinar. As you know, we had a trying time these last few months, so we decided what a fitting topic if we did one on COVID-19. So this webinar is done in collaboration with ROCHE Diagnostics Malaysia. And so we would like to thank ROCHE Diagnostics for their help in giving us an educational grant and also helping us in a few of the technical issues like what we're having now. So the title of this webinar is The Role of the Laboratory in the Battle Against COVID-19. This webinar will focus on the experiences of Malaysian laboratories involved in the testing of COVID-19 patients. So without further ado, I would like to introduce the first speaker. We have changed the program a little bit. Okay, so the first speaker will be Dr. Donal Huda Nasril from the National Public Health Laboratory in Sungai, Buloh, Malaysia. She's a clinical microbiologist in the disease division of the National Health Laboratory, and her interests include clinical microbiology and diagnostic virology and molecular and transplant virology. So without further ado, I will invite her to speak on serology testing for COVID-19. Dr. Huda.
I'm live now, is it?
Yep.
Okay. Thank you, Madam Tengku Marina, for that kind introduction. So I'll share my slide first. Okay. The topic of my presentation today is serology testing for COVID-19. Can I proceed?
Yeah, should be okay.
Okay.
Go ahead.
Okay, this is my topic for today, serology testing for COVID-19. And this is the outlines of my presentation. I will talk a bit on the introduction, COVID-19, background, the COVID-19 serology testing, sensitivity, specificity, okay, and then the correlation of the serology testing with neutralization testing, and as well as the patient immunity, interpretation of COVID-19 serology results, and what we do for serology in Malaysia, and last but not least, the challenges and also way forward. Okay, for introduction, we recap a bit about this COVID-19 pandemic. As we remembered, it started in the middle of December, where it started in a city called Wuhan in China, where about 43% initially infected with this unknown virus that causing pneumonia. And then on the 31st December, the Wuhan Municipal Health Commission has shared with World Health Organization about the outbreak, and so many testing work out to know that what kind of disease that we deal with until on the 10th of January 2020, where the Wuhan scientists first shared the whole genome sequencing of this virus, and at this time we call it novel coronavirus. Okay, and this is when the whole world started to diagnose this novel coronavirus with the whole genome sequencing shared by the scientists. Okay, and then this is actually the first article in our country that diagnosed our first few cases that was imported from Singapore. Actually, some tourists from Wuhan, they have a vacation in Singapore, and all the close contact of those positive cases in Singapore traveled to our south part of Malaysia, Johor Bahru, and the Ministry of Health Singapore contact our Ministry of Health to trace them. And this is when the first cases diagnosed in the lab that I work now, Makmal Kesihatan Awam Kebangsaan, or National Public Health Laboratory, around 24th of January 2020. So this slide showing the current situation where the cases of coronavirus now is already 23 million all over the world, and the death is already 812,000. And in Malaysia, in our country Malaysia, the total cases up to yesterday is 9,274, and death is 125. Okay, and I'll share a little bit on the coronaviruses. This is just to recap back. Coronavirus is enveloped RNA virus that are distributed broadly among human, mammals, birds, and it causes respiratory, enteric, hepatic, and also neurological diseases. Okay, as you can see from the top chart over there is the classification of the coronaviruses, and the SARS-CoV-2 is actually under the group of genus Beta coronavirus. Okay, different from MERS-CoV. Okay, and then this next slide showing all the coronaviruses that can infect human. The above 4 viruses, the common human coronaviruses 229E, NL63, OC43, and also HKU1. Actually, the coronaviruses that only cause mild illness such as influenza-like illness. Okay, but the below human coronaviruses, MERS, SARS, and the current COVID-19 are the beta coronaviruses that cause more severe illness. Okay, for diagnosis of COVID-19, there are some testing that can be done for diagnosis of COVID-19, but of course, the real-time RT-PCR is actually the gold standard. You can also test by sequencing, but it's kind of laborious and time-consuming. Okay, and then the other testing methods are virus isolation, electron microscope, and also serological testing. For gold standard of COVID-19, the RT-PCR, which detects the presence of the virus RNA, and this is the gold standard by World Health Organization. It has high sensitivity and specificity, but the sensitivity actually decreases over time from the onset of the symptom, and it can also be affected by the quality of the sample collection. Okay, and it can actually only diagnose the current infection, but it cannot indicate whether someone has previously infected with SARS-CoV. Okay, and this is what WHO tells about serological testing. This one is adapted from the interim laboratory guideline, WHO, where it stated that serological survey can aid the investigation of ongoing outbreak and also be the assessment for retrospective attack rate or extent of an outbreak. And in case where the nucleic acid testing are negative, but there is strong EPID link, the PET serum can be used for supporting the diagnosis. But bear in mind, for serology testing, also there are cross-reactivity to the other coronaviruses that I mentioned in the earlier slides. Okay, this is just recall of the serology testing. It's actually the blood-based test that can be used to diagnose whether people have been exposed to any particular pathogen. Okay, and it uses serum to analyze from the whole blood, and if the serum has antibodies to the specific component of the pathogen, for example, the antigen, okay, where our immune response will recognize this antigen. And in viral infection also, it can be used to see whether the patient has immune response to a pathogen. And it can also be aid for diagnosis of any disease. Okay, for COVID-19 serology assay is kind of different from the other viruses. It can detect the host antibody response to COVID-19, where it detects the immunoglobulin A, M, G, or total antibody. Okay. There are some evaluations done independently from many manufacturers, and many studies also shows that the sensitivity and specificity from these tests actually range broadly from 0% to 100%. Okay, and then correlation between COVID-19 serology assay and neutralization assay also varies. Okay, and the correlation with patient immunity, whether they can protect the individual from the next infection, is not known currently and need further study. So far, the confirmed part of this serology assay only determine the past exposure to COVID-19, and to interpret the result, caution need to be taken. Okay, currently all over the world, actually there is more than 200 commercial serological testing already available.
So I will resume my presentation. I'm sorry for the problem, the technical problem occurred. Okay, so this slide showing there are currently about more than 200 commercial serological testing available, and the test can be immunoassay, which can be manual or automated, or rapid diagnostic test or POCT. The examples are EIA, CLIA, gold immunochromatographic assay, and also lateral flow immunoassay. And there are also neutralization assay, which detects the functional neutralizing antibodies, but not used routinely for clinical testing. And the picture showing here are examples of the testing tools. On the right top, the EIA. On the left, the rapid testing kit. And down there, on the right down, is the ELISA. Okay, for the antibody isotopes, the COVID-19 serology tests have been designed to detect a variety of antibody isotypes, which are present at a different time of during infection. It can be IgM, IgG, and IgA. And the picture here showing when those antibodies produce, for example, IgM that produce around first week of infection, but it disappears during the third week of infection.
Excuse me, Dr.
As well
Huda.
as the IgA.
Tak nampak lah, Dr. Huda. Can you change the slides? I mean, the slides are not changing. Where am I now?
Okay, can you see the slide now? It's showing a graph there.
Yeah.
Antibody isotopes. Okay. All right. So the antibody isotopes, for example, IgM, IgG, and also IgA. As you can see from the picture there, it shows when the IgM, IgG, or the IgA produce, which IgM produced during the first week of infection, around day 7, and disappears during the third week of infection, onset of infection. And IgA actually is about the same of IgM, but IgG produced later during the second week and remains in the blood, but currently it remains in the blood for unknown duration. Okay, this is pictures of just recall of the antibody, IgG, IgM, and also IgA. Okay, as I mentioned just now, IgM actually is the marker of the early infection. This slide showing the IgM. For those who has been lost to my presentation, just now I show all the antibody that can be produced. And then this is IgM that is the marker of early infection. It can be detected in the first week of infection and peak at 12 days. And usually can be detected until the day 32 or lesser than that. Okay, and then IgA, as I mentioned just now, it comes almost the same time as IgM. IgA, as we know, is produced by the mucosal surface and can be used to diagnose infection that affect the respiratory mucosa. Okay, and it also actually declines as same time as the IgM. But IgG that actually developed later as compared to IgM and IgA, and it continues to circulate in the blood after the IgM or IgA drops. Okay, and it can be detect longer time as compared to IgM and IgA. For SARS-1, actually, for SARS-CoV-1, it can persist for several years. But for SARS-CoV-2, is still currently unknown. Okay, what are the viral antigen that used for serology testing of COVID-19? Okay, for COVID-19 serology, they use commonly use the spike as protein. As you can see from the picture there, the blue protruding spike protein is the S protein, and the inside nucleocapsid N protein are also used as the antigen for serology testing. And this is the 3D picture of the S protein. Is actually the viral surface protein that used for the binding and fusion to the host cells during infection. Okay, some of the assay detect the whole S protein, some regional or the receptor binding domain or RBD. Okay, and the S protein is actually more divergent protein and allow for better differentiation from the other virus and have greater specificity. Since the S protein protrudes from the viral membrane, it can easily recognized by the host immune system. And it also induces most of the neutralizing antibody. But among the S protein, RBD is actually more conserved than S1 or also the full length of the S protein. Okay, this is the picture showing the region of the S protein S1, S2. Okay. And what about N protein? N protein actually is the structural protein that binds and package the viral RNA. And it is most abundant protein in the SARS-CoV-2. And for N, actually, it is as compared to the S protein, is more conserved, okay, across the all other coronaviruses. Okay, how about the sensitivity and the specificity? For sensitivity, it range from 0% to up to 100% for both IgM, IgG, or some of the testing AC use the total IgG or total IgM and IgG. Okay, and the determinants for the sensitivity actually includes the testing factors and also patient factors. I will explain on this. For the test-related factors, the lab-based test, means the assay, actually has a higher sensitivity as compared to the point of care testing. Okay, and the sensitivity is also varies, depends on which antigen do you use. It's either the N, the S, or the other parts. Okay, and the sensitivity also will be depend on the laboratory cut-off that being set to the from the manufacturer. And the lower cut-off definitely will increase the sensitivity, but can expand the specificity. Okay, for commercial kits, the cut-off usually will be set by the manufacturer. Okay, how about the patient factors? Patient factors is depends on onset of the symptom. When do you take the samples, the serum samples? Okay, and some patients actually do not develop antibodies. Okay, this has some papers has shown this proof for some patient that not even develop the antibody or develop maybe low, very low that can't be detected by the assay. And severity of infection also be the factor for the patient, where the mild infection usually will generate less antibody as compared with the severe infection. And it also, the study shows from the Wu et al., the study shows that middle age and older individual actually had higher COVID-19 titer as compared to younger individual. But some of the factors actually not significant or not known, such as comorbidity of patient, the patient with immunocompromised state, and also medication. Okay, how about the specificity? It also range like sensitivity. This is from 6.9% to 100% for IgM and 0 to 100% for IgG. Some of the commercial assay actually exhibit very excellent specificity. And it also determines by the test factor and also patient factors. For the test factor, for antigen use is one of the factor. For SARS-CoV-2, and protein actually is almost 90% similar to the SARS-CoV-1. And the SARS-CoV-2 S1 region of S protein also similar about 90% to the SARS-CoV-1. So this will affect the specificity of the testing. Okay, and It is also a study done by Ma et al. Shows that specificity of IgM and IgA based testing for COVID-19 may be lower than IgG. So this is why we can see that most of the commercial kits prefer to test IgG as compared to IgM and IgA. Okay, the test-related factor, the assay cut-off, as I mentioned just now, it depends and will be set by the manufacturer. And also there are cross-reactivity with the other coronavirus in some assay and some kits. For example, for SARS, MERS, the seasonal human coronavirus, okay? And over 90% of adult, over the 50% of age actually already have antibody to seasonal coronavirus. So this might give result of false positive. Okay, and patient factor, for example, rheumatoid factor, heterophile antibody can also cross-react and give a false positive result. Okay, now we talk about neutralization assay. This is one of the serology assay as well. It is actually a gold standard method to measure the functional humoral antibody, and it provides a relative measure of the quantity of antibody present. As you can see from the right picture up there is the PRNT testing, plaque reduction neutralization test. Okay, and the other example testing is microneutralization assay. But actually not every antibody produced during the immune response can be neutralized by virus. And this neutralization assay requires expertise, requires laborious method, and also must be conducted in BSL-3 facility, because it used the live virus. Okay, and correlation between IgG, IgM, and IgA, as well as the neutralization assay, also varies. And there are limited studies done. There are some factors that affect this, which are the different testing method performs, the antigen use, the cut-off use, and as well as the onset of the sample taken, okay, timing of the sample taken. And there are proposals from one study that proposed that in general IgG and IgA actually contribute more to neutralizing immunity as compared to IgM. Okay, this slide showing the correlation between serology testing with immunity. So does it mean that if you have antibody, you are immune to the virus? Okay, you can't get the infection. Actually, in the other pathogen, okay, for example, in chickenpox and some other pathogen, IgG antibody levels often create immunity against that particular pathogens. But for COVID-19, so far it is not known. Okay, and it is also not known whether the threshold immunity determine the duration of protection of the infection. Okay. And current data suggests that humoral antibody immune does not or its own determine the immune to COVID-19. Okay, so there's all these studies actually shows that there's no correlation between presence of antibody and also the immunity, and more study need to be done for this. Okay, this is actually taken from last 2 days article that this article shows that the first case of COVID-19 reinfection reported by researcher in Hong Kong, where this particular patient has been reinfected by the virus after 4.5 months having the first infection. So this is one of the proof that your exposure to the virus won't protect you to get the reinfection. Okay, the interpretation of COVID-19 serological testing also need to be done with caution, okay? Because if the serology test is positive, it does not necessarily indicate that a patient is immune to COVID-19. And how to interpret the result? If the positive serology test, it only can say that this particular patient has been exposed to COVID-19. Okay. But it also depends on the test characteristic of the assay use and also the prevalence of the population that been infected by COVID-19. If the infection prevalence low, the positive predictive value will be low. For example, if a country with a 5% prevalence, a positive predictive value is only 49%, meaning that less than half of the positive testing serology is actually true positive. This is quote by CDC. Okay, and then what is the negative serology test mean? Okay, the negative serology test does not necessarily mean that patient has not been exposed to COVID-19. And this also depends on the test characteristic and the time between exposure and testing. For example, if you take the sample quite early and the patient haven't developed the antibody, means that the negative result doesn't mean that the patient is truly negative. Okay, how is the serology testing done in Malaysia, in our country? Okay, in the Ministry of Health guideline, it stated that this serology testing is used for the day 13 testing at the public health and also private facilities for the patient under surveillance. Means that if the patient has contact with the positive case or the patient this patient is negative for the first test and will be put under surveillance. On the day 13, the sample will be taken by serology testing only. Okay, and then if the test is positive, we will repeat with PCR to confirm that this patient is having COVID-19. And if it's positive, this patient will be admitted to hospital as the positive case. Okay, what are the testing kit available in Malaysia? In Malaysia, all the serology testing kit that can be used actually have to go through under medical device authority, and it will go through the special access. And in this special access, evaluation of the test kit will be done. And if the test kit meet the standard of the testing, the MDA will recommend this test or this test kit to be used, and the list will be forward to MMA, Malaysian Medical Association. Okay. And serology testing in Malaysia also used for the seroprevalence study in COVID-19. This is done in the hospital, in the many other settings to look for the seroprevalence, not for diagnosis. Okay, And the evaluation testing kit currently is ongoing for both RTK antigen and also the serology testing, whether it's assay or whether it's point of care testing. Okay, and this is actually my last slide, the challenges and way forward for serology testing. For currently, it is not recommended to use as a screening tools, okay, because not many tests now have high sensitivity and specificity, and the result might give a false negative or even false positive result. More evaluation and comparison study need to be done to look for the need of the serology testing. Okay, and if RTK or if serology testing can have better sensitivity and specificity, it can also be one day replace the molecular testing, which very laborious and expensive to be done. Okay, and serology testing can actually reduce the burden in molecular testing and also increase the testing capacity in a country which have low or median income, and also which have limited access to molecular testing, which the standard gold standard method to diagnose COVID-19. And we need more study for this serology testing to look for the immunity towards COVID-19. Okay, I think that is the last of my presentation.